Hey all, welcome back to the Real Life Pharmacology Podcast. I am your host, Eric Christensen, and I thank you so much for listening today. Hopefully you can pick up some practice pearls and good medication education here. So today I'm going to cover Doxepin. So Doxepin, brand name Sinequan, that's an older brand name, and there's also a newer brand name product, Silenor, as well, which is a lower dose medication intended for sleep. They are both forms of Doxepin there. In my mind, way for a drug company to make a little bit more money off the sale of Silenor, the low dose that they've studied for sleep. But anyway, we do have this medication is a TCA, so it's a tricyclic antidepressant. So mechanistically, how this drug works, it's going to be like your amitriptylines, your nortriptylines, which you can go back and listen to those podcasts in the past. But essentially, it's inhibition of serotonin and norepinephrine reuptake, which in the end increases the amount in that synapse and available for activation and physiological effects. So that's the primary class that Doxepin comes from. Okay. However, it does have other mechanisms of action, and one of those primary mechanisms of action, other than the TCA effect with the SNRI type effect, is it can block histamine. Now, if you remember from previous episodes, that blockade of histamine can lead to a couple of different effects. So one is anticholinergic, so we'll talk about that in adverse effects. But antihistamine effects can cause sedation and sleepiness. So antihistamine, good for itch, good for insomnia. And that is the situation where I've seen this medication used the most. Honestly, I cannot recall the last time I've seen Doxepin used for specifically for depression. The most common situation I've seen it used for is a combination of insomnia and itch. Okay, so that's, I think, likely where you're going to see it the most, because we're treating insomnia and maybe some itching at night. Obviously, this drug is going to be dosed in the evening or at night. Okay, so those adverse effects, it can be very sedating for some patients, and again, it really is a dose-dependent effect. So the higher the dose, the more likely you're probably going to have those sedative-type effects there. Other considerations, adverse effects, there is a boxed warning with antidepressants, and Doxepin is under that classification. So don't forget about that. I went through that a little bit, but suicidal ideation and those type of risks. The antihistamine, anticholinergic type effects. This drug is on the Beers list. Okay, so especially as we get to higher doses, that's going to lead to more and more anticholinergic effects. So those anticholinergic effects, they can cause memory problems and confusion, dry mouth, constipation, urinary retention, dry eyes, which can be really, really problematic in our geriatric patient population, especially. So very important to remember this drug. Definitely not an ideal agent if we're strictly using this just for insomnia, at least in my mind. Drugs like trazodone and things of that nature may be a little bit on the safer side, especially when it comes to those anticholinergic effects. I do want to mention a couple other adverse drug reactions that's maybe in relation to its mechanism of action as a TCA with the norepinephrine and serotonin type effects. So first one I wanted to mention, obviously serotonin risk. So if you've got a patient on serotonergic drugs, it could add to that effect and contribute to a serotonin syndrome type of situation. Again, extremely rare that serotonin syndrome ever occurs, but as we add on more and more drugs that could have that activity, it has to come into our risk calculation as far as if this is going to be a concern or not. One other one I did want to mention was SIADH. So, antidepressants in general, a lot of them that deal with, that have, I should say, SSRI activity, which Doxepin does have that serotonin reuptake type activity. So it's important to remember that. And any potential patient that has hyponatremia, there is a potential that Doxepin could increase that risk of contributing to that. Okay, let's take a quick break from our sponsor, MedEd101.com. If you're in the market for board certification study material, such as NAPLEX, BCPS, BCACP, BCGP, or BCMTMS, definitely go check out our study materials at meded101.com/store. We've also got general materials for clinicians in general. So if you're a PA, nurse practitioner, maybe a med student, physician, nurse, we've got materials there. Just recently released a drug interaction book. So go check that out. I cover easily the top 200 drugs in that book and point out some of the most common interactions, and more importantly, some questions to help assess those interactions and identify how serious some of those drug interactions are. So definitely go check out all those resources, all the links, meded101.com/store. Okay, so let's finish up on drug interactions with Doxepin. So the biggest one from a metabolism standpoint with Doxepin, I think about CYP2D6. So Doxepin is metabolized by CYP2D6. So if we have an inhibitor or an inducer, that can alter the concentrations of Doxepin. Specifically, some of the most common inhibitors I see used, bupropion, paroxetine, fluoxetine. Those drugs can inhibit CYP2D6, which is going to lead to higher Doxepin concentrations and that potential to run into some of those anticholinergic, antihistamine type adverse effects. Now, there are a few other drug interactions besides CYP2D6 that I want to mention. Serotonin syndrome, I kind of talked about that already. Additive effects with SSRIs, maybe a tramadol, all those type of medications that have serotonergic activity, Doxepin could add to that. So something that, we keep an eye out for and obviously recognize if patients are on higher doses of some of those serotonergic drugs, Doxepin could increase that risk for serotonin syndrome. Anticholinergic additive effects. So I think of, some of your over-the-counter antihistamines, maybe a situation where a patient picks something up over the counter, maybe they start taking Doxepin, they say, hey, this isn't, working really well, or I need it to work a little bit better. So now they start taking, an over-the-counter sleep agent, a Unisom, a Benadryl, diphenhydramine to kind of add to that insomnia benefit or that, sleep type effect. Well, we're also doubling up on a lot of those anticholinergic effects. So your confusion, your dry mouth, your dry eyes, those can all be added on top of what Doxepin already does there. Sedation. So sedative effect, not just from an anticholinergic antihistamine perspective, but if we've got other sedatives, so, a trazodone on board, if we've got a benzodiazepine on board, opioids on board, that in combination with Doxepin could kind of exacerbate that sedative type effect. So what you might want to do in that situation is obviously be more conservative, maybe with dosing, and or reduce some of the other agents that may be sedative if we're adding this on board. When you're adding any new medication for insomnia, I strongly encourage you to take a look at that medication regimen and make sure that patients aren't already on something for insomnia. This is one of the areas of polypharmacy that I see all the time. So a patient starts taking melatonin over the counter, then they, doesn't work for them, so or doesn't work very well, so then they report it to their, primary care provider. Their primary care provider adds something. They come back months later, I'm still struggling with sleep, and that type of thing. And, then we get a new medication or a different medication on board, or they go try another over-the-counter supplement or medication, okay? So this is really an area where we can pay attention, make sure patients aren't taking multiple medications for insomnia, because that definitely happens out in practice. It's something I see on a pretty regular basis, more often than I would certainly like to see it. So definitely pay attention to that adverse effect and that risk for drug interactions and a cumulative type effect. And then one last one, QTC prolongation is a potential concern with Doxepin, and it's obviously going to be more concerning if we add it on board to other drugs that can add to that effect. Your antiarrhythmics like amiodarone, your QTC prolonging antipsychotics, for example. So there's lots of different medications that could prolong the QT interval, but that's definitely a risk assessment that you need to think about and talk about. And I do talk about some of those cases and kind of my strategy and approach in dealing with some of those cases in my new book, Clinician's Guide to Common Drug Interactions in Primary Care. So definitely go check that out. Support the sponsor, meded101.com/store. Also, snag your free PDF at reallifepharmacology.com. Quick and easy to sign up there. Simply follow the podcast. Get your free 31-page PDF on the top 200 drugs. Lots of real-life clinical pearls with regard to the top 200 drugs, as well as stuff that shows up on exams. Believe me, I've taken a lot of pharmacology exams throughout my career, and it's definitely stuff that you will be tested on at some point throughout your career if you have to do any certification, recertification, or if you're in school looking to pass some of those exams. So go snag that resource for free. If you enjoyed the podcast today or enjoyed any of our other podcasts in the past, definitely leave us a rating review. It helps us reach more people. If you've also enjoyed the podcast, share us. Send it out to your email listserv, your classmates, whoever you think could benefit from the podcast. We greatly appreciate that grassroots support, and it keeps me going and helping to try to reach new people and share medication education with some new healthcare professionals, as well as maybe some older healthcare professionals. So I'm going to sign off for today. Track me down on reallifepharmacology.com, meded101.com. Hit the contact me button. You'll track me down. Social media platform, LinkedIn, is probably the one I'm most active on. So if you want to, go ahead and friend me on there or connect with me on there. Feel free to do that. So signing off for today. Thanks so much for listening. Take care and have a great rest of your day.